is diagnosed with Alzheimer's dementia. So this is a big public health concern. Well, let's begin by defining what it is. In 1906, Alois Alzheimer presented the first case to the medical community. It was a 51-year-old woman who had psychosis and confusion, so she was out of touch with reality. She had a very aggressive illness. In 4 years, she died. And what he did that was novel was to do an autopsy and apply special stains to the brain tissue. And he found in her brain these amyloid plaques, these little round, proteinaceous, waxy, filamentous deposits, and these elongated tangles, abnormal protein deposits. And they collected in areas of her brain that control brain health. All those functions that I was talking about a moment ago. So this was a big breakthrough, but the medical community assumed this was a rare presenile dementia because the woman was only 51 years of age. Now, years later, pathologists did autopsy studies on older people who had what we then called senility. We used to assume that as people got older, they just became senile, and it was a normal part of aging. When they did those autopsy studies, they found the same plaques and tangles in these older individuals. And so now we had early onset Alzheimer's and late onset Alzheimer's. Now what that also resulted in was an epidemic of Alzheimer's disease, because all of a sudden all these older people weren't just normally senile, they had a disease. That was frightening in part, but it also pushed scientists to begin to look for better diagnostic tools and also for better treatments. Now if you look at a normal brain, you see it's nice and plump, and if you look at an Alzheimer brain, it's atrophied or shrunken. And here you see these insets show you in the frontal lobe and the temporal lobe these concentrations of plaques and tangles. In fact, they're sort of regional. In the medial temporal lobe, there's more tangles, and in the frontal lobe and the parietal lobe, there's more plaque. But look at the healthy brain. You see an occasional plaque, and you see an occasional tangle. And it turns out that these proteinaceous materials that define the disease start building up in our brains years, even decades before we have symptoms. And I'll get into some of the evidence for that in just a moment. But let's define a couple of other terms that I'm going to be using. First, memory. Now, memory is a very complex function, but to keep it basic, we can think of two components to memory: learning and recall. So we have to learn the information, get it into our heads, and we have to be able to retrieve it later. I also use the term cognition, which encompasses memory, but other mental functions: attention, thinking, reasoning, visual spatial skills, so the ability to read a map. And then there's the term dementia, which also many people equate with senility. It's basically memory loss, another cognitive impairment, and the impairment is to the degree that it interferes with everyday life. So people with dementia need help from others. And the most common cause of dementia is Alzheimer's disease. That's where you have the plaques and tangles in the brain. It has a gradual onset and progression. But many different things can cause dementia. You can become demented from having small strokes in your brain, and there the onset might be sudden. Or it could be a sudden onset from a depression, and that can be a treatable, reversible dementia. Or you can be demented from a thyroid imbalance. Medications can cause dementia. One of the first patients I saw with a diagnosis of dementia when I was in my training was taking 10 milligrams of Valium a day. I stopped his Valium and I cured his dementia. So it's important, if somebody has a cognitive impairment and it's interfering with their daily life, that they see the doctor, because not only can there occasionally be a reversible cause, but even if it's Alzheimer's dementia, there are treatments that can help. So the most common memory complaints. Anybody want to take a guess if you can remember it? Somebody's got to blurt it out. I can't. Names, that's right. 85% of older people complain about names. And then somebody said words. I'll get to that. Where you put things, memory places. Prospective memory, so you leave the house and you forget your cell phone. And then the tip of the tongue phenomenon, where you should know that word, it just doesn't roll off the tip of the tongue. Now, those first two common problems, you can get, there's a lot of places you can get techniques on improving that. The last two, there's not, I couldn't find anything out there on it. And so I was adamant about getting it into this new book. So we have, for the first time, practical techniques that really work for these last two annoying memory complaints. So these are common. Everybody has these problems, and we'll talk about how you can alleviate them. But first I wanted to segue with another example of successful brain aging, my wife's 104-year-old grandmother, Grandma Ollie. And I would like to disclose that at the time that we took this photograph, I was not injecting myself with anabolic steroids. Grandma was very short to begin with. And relevant to that issue was that she did not take estrogen after menopause. And she probably got shorter because she developed osteoporosis and compression fractures. And there have been some studies looking at estrogen as possibly protecting an older woman's brain, and there's mixed results. The latest data suggests that if a woman takes estrogen around perimenopause in midlife, it may be brain protective. But if she takes it later in life, after age 65, at least the Women's Health Initiative found that for certain forms of estrogen, it can actually accelerate cognitive decline. So this is true about many different treatments. A similar phenomenon with anti-inflammatory drugs, that earlier in life that may be helpful, later it may accelerate the problem. There's a tipping point that we don't quite understand. And in fact, in the book, I have a section where I talk about, first I begin with the three most important words in real estate. Everybody knows, right? Location, location, location. In this area, it's timing, 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 because the timing of the intervention is critically important. I think one reason we have not been as successful as perhaps we could be with some of the new drug development with Alzheimer's disease is we've been testing those drugs too late after people have dementia. We should be using them in prevention trials, which is what's starting to happen now. But getting back to Grandma Ollie, she did very well. She lived in an apartment without an elevator, so she was physically active. She was mentally active. She was kind of a feisty woman. If you forgot her birthday, she would let you know about it. And she was very proud. I mean, she was 104, and I knew her risk for dementia was high. Even though she was always pretty good, every time I saw her, I'd always worry about her, and I'd want to do a mental status exam, and she would not let me do it, so I'd have to sneak it in. So I remember this visit. I started off the conversation by saying, "So Grandma, how old are you now?" And she said, "Shut up." So she passed her mental status exam. She did. Now, she did very well. I kind of mentioned a lot of these things that can cause dementia, but there are many different conditions: vascular dementia, Lewy body disease, frontal temporal dementias. Head injury is important. We just did a study looking at NFL retirees, and we used our PET scanning, the chemical I'll talk about in just a moment. And I can't really talk about it because of a press embargo on it, but it'll come out on Tuesday. And it's actually being reported in the American Journal of Geriatric Psychiatry. So my colleague, Dilip Jesta, who's the editor, unfortunately, he just got back from India. He couldn't be here tonight, but he's the director of the Stein Institute, isn't he? But it's in his journal that it's going to be published. And there's a lot of interest in this. But head trauma is not good for the brain, as are many other things. What we find, in fact, if you look at an autopsy series of patients with Alzheimer's disease, you'll see those plaques and tangles, but especially if they're older, you see a lot of other things gone wrong. You see a lot of vascular disease, you see evidence of head trauma. So the brain gets knocked around with age. And a lot of the strategies I'm talking about are helpful regardless of what's happened to our brains as we've aged. Now, genetics are important, but they're not the whole story. There are rare mutations, and I've listed them here, presenilins, APP mutation, that cause the disease. And these occur in families where 50% of the relatives get the disease, usually at a younger age, age 50 or 60. And if you're in a family like this, we call it autosomal dominant inheritance pattern, then genetic counseling may be helpful. But for most people, that's not the case. And we're learning more about the genetics. The biggest breakthrough for the common genetic risk was ApoE4 a number of years ago. And we were fortunate, our group collaborated with Duke University on this, and we were involved in those discoveries. And the bottom line is that 20% of the population has a form of this gene, ApoE4, and it increases their risk of Alzheimer's disease. But it's not necessarily meaning that you're going to get it. So we don't recommend it as a predictive test. We use it in our research because it can be helpful in determining who's going to respond or not respond to a certain treatment. But we generally don't recommend people get ApoE testing. And there's some newer genes that have been discovered. There's a TREM gene that just was discovered. And I mention that because it's a gene that's linked to immunity and inflammation. So again, it goes along with that inflammatory story. Or actually, it's not inflammatory, the story, but it's a story about inflammation. So we've, at UCLA, done a fair amount of work with PET scanning, positron emission tomography, and it's basically a simple explanation of a PET scanner. It works like a Geiger counter. So it measures radioactivity, and in these experiments, we